this time, I would like to introduce to you our speaker, Fran Feltner. Dr. Feltner is the director of the University of Kentucky Center of Excellence in Rural Health, located in Hazard, Kentucky. She is the principal investigator of Kentucky Homeplace, a community health worker program which has been recognized by the Center for Disease Control, Healthy People 2020, and the National Rural Assistance Center for Successful Models and Innovation. Dr. Feltner has more than 40 years of experience in rural health care. Much of her work has focused on improving the health of the Appalachian population and empowering rural communities to directly address the health disparities that affect them so seriously. Her research includes exploring the social determinants of health and their effects on health outcomes, finding effective linkages between vulnerable populations and the healthcare system, and examining the role and impact of community health workers. Awards and honors include fellowship in the American Academy of Nursing, the Paul Mason Memorial Award in recognition of contributions to benefit Kentucky's indigent and underserved population, and the Dan Martin Award in grateful recognition for enduring contributions to the health of rural Kentuckians. Now, I'll turn it over to Dr. Feltner.
Good afternoon, everyone. I appreciate the opportunity to be able to come and discuss something that is so near and dear to me, our community health workers. I'm presenting to you today from the Center of Excellence in Rural Health, where we improve the health of rural Kentuckians through education, research, service, and community engagement. An overview of our objectives today, we will look at an introduction of our community health workers, some history, we'll define our community health workers, why we need community health workers, where are our community health workers in the healthcare system, today's community health workers, and what future community health workers might do. As an introduction to our community, we see increasing challenges, rising healthcare costs, the increase of many of our population with chronic disease. We work with community health workers and have found that they are cost-effective bridges between our patients with the greatest needs and with primary care providers and other healthcare providers. Because community health workers are trusted, they are known by their community, they know their community, they are able to reach and address health disparities and special needs. We will explore today the strengths of community health workers and how they can be added to the team to more effectively address the needs of our communities. In discovering the missing link in the history of community health workers, I found a definition by Merriam and Webster to define the missing link as something that you do not have and that you need to complete a series or to solve a problem. In our rural areas and in our health disparities populations, community health workers have become that link. They are successful in providing access to social and the medical care needs of our population. Community health workers have been identified in many different strategies, working in countries and in communities where shortages of healthcare workers are, particularly in those low-income countries. Using community, using community members to render certain basic health services to the community has been around about 50 years now. There are many experiences throughout the world, ranging from using large-scale national programs to small-scale community-based initiatives. Community health workers have been called by many names, and in the early 300s, China actually used the word forerunner of the barefoot doctors. Our World Health Organization has used the word a key to health success. Community health workers have been identified as a local solution to a global problem. Over the past few years, many people in many healthcare systems have worked to define who community health workers are, what they do, who they serve, and how they are trained and where they are better utilized. As you can see, a definition has been described as a frontline public health worker who is a trusted member and has a close relationship with the community that they serve. They do work as a liaison and a link between our health and social services. They are facilitators in the community. They help us improve the quality of health and the quality of care. A community health worker also builds individual and community capacity. They increase our knowledge and help us to be able to reach the populations we serve. When we defined a community health worker, we explained that community health workers do not provide clinical care and are generally do not hold another professional license. They do share their life experiences, and often these experiences help the communities that they serve. Community health workers have been improving health outcomes throughout the country. They culturally tailor their healthcare needs in the health disparities populations they serve to reduce the problems and the barriers. Sometimes it's transportation, sometimes it's making an appointment, sometimes it is simply translating what the doctor has said. They also use cultural competency, and they provide an effective communication with the people that they serve in order to access services for them. They work in the healthcare systems in many different ways. They may be an extension of the hospital system where they become members of the healthcare team as they work with the planning discharge of a patient so that they can access the things that the patient needs before leaving the hospital. These things may include medication, medical equipment, or even the basic needs of life, such as food, making sure they have electricity, a handicap ramp, to name a few. Community health workers are also community-based, and they connect to navigate access to the health delivery system. Community health workers increase access to preventative screening. They may work with the mental health teams by providing access to care, housing, medication, making appointments, and calling patient reminders. They may work in primary care centers with FQHCs or rural health centers where they assist patients with understanding life management, self-management of their disease, and how to ask providers questions. They may access transportation and, again, remove the barriers of the social determinants of health to improve their health outcomes. They may help the healthcare centers in improving their HEDIS measures and their outcome measures and increase screening for their patients. When you look at health departments, community health workers are key to population health and in reaching those community members. When you look at rural health challenges, community health workers are very effective in working in special populations where there are many barriers to overcome. The community health workers work within their own population, and they understand the issues and they understand the barriers. People living in rural America die younger than people living in urban America. Community health workers help us to overcome these challenges. The cost of hospital admission is a growing concern to the nation and to our healthcare system. 1 in 12 adults are readmitted within 30 days at a cost of $16 billion. These readmissions are growing at a cost of $97 million annually when including patients that are readmitted to the hospital within 1 year. When you look at the number of deaths and the leading cause of death, we see that in Appalachian and Kentucky in particularly, our population is considered part of the diabetes belt. It is the center of the stroke belt. It is in cardiovascular valley. Community health workers can make a difference here. When we look at the burden of chronic disease, 145 million, more than 1/2 Americans live with chronic conditions. This number continues to increase and is estimated to reach 171 million by 2030. Management of chronic diseases and education is a must. When the team sat down to discuss what the deficiencies included, these are a few that were mentioned. Rush practitioners not following established guidelines, lack of care coordination, lack of active follow-up to ensure the best outcomes, patients inadequately trained to manage their own illness, or provided health coaching. When you look at what community health workers can do to relieve some of those barriers, they can access the healthcare system. They can improve the lack of understanding on how to navigate the healthcare system. They help the uninsured, the underinsured, and the underserved. They provide access to transportation, access to primary care providers, providing the healthcare needs at the right place, at the right time, at the right cost. They access medications that otherwise patients would not have the ability to afford. They provide health coaching where health literacy is a problem, just interpreting what the orders or the suggestions that are made for improving your health are followed. They access the illness education, that if you have diabetes, here is how you self-manage. If you have chronic diseases, here's how you manage those diseases, and absolutely help them understand how they can live healthy. Communication is very important, as they are culturally sensitive to the community that they serve, and they are very good at removing the social determinants of health so that improved health outcomes can happen. In Kentucky in the early 90s, we discovered the missing link, and the missing link was our community health workers. On your left is Dr. Guilford Dale, who was a pathologist that saw many late-stage cancers, and he reviewed the low preventative screening rates. He trained women from the community to talk to their neighbors and friends about screening in order to increase the screening rates so that cancers could be found at an early stage. On my right is late Representative Paul Mason from Letcher County. He was an advocate for the underserved. His daughter, pictured in the middle, contracted the AIDS virus during the blood transfusion. She was not treated well by the health system. Representative Mason wanted to develop a program to provide home visits, meeting people where they live, complete an assessment, and help people access the care that they needed. He worked with Dr. Friedel and many other legislators to start the Kentucky Homeplace program that we have today. Kentucky Homeplace has been considered a national and a successful model. Their mission is to provide access to medical, social, and environmental services for the citizens of the Commonwealth. Our vision is that we can educate Kentuckians to identify risk factors and use preventative measures to become a healthier people with knowledge and skills to access the health and the social system. Today we serve 30 counties within Appalachia where the rates of illness are the highest in the country. Homeplace is a successful model. In 1 year, this last fiscal year, served over 4,000 people. They accessed $7 million in services and medication with a return on investment of $5.98. When we combine totals from July 2001 to 2016, they have served over 150 individuals during that time, providing over $308 million in services and medication, with a return on investment of $11.55. Other programs across the country have replicated what Kentucky Homeplace has done. And one of our newest programs is Connecting Kids to Coverage, which is an outreach and enrollment cooperative agreement with CMS to reach a population of families and children who need access to health care, access to insurance. Community health workers across the country may have many roles and responsibilities that have been identified. In Kentucky Homeplace, our roles include outreach and community mobilization, assist care management teams and care coordination, home-based support, where we provide home visits, health promotion and health coaching, where we can help our patients and our clients to be able to understand what they need to do to improve their health, system navigation, and participatory research. One of the things that we have found that looking at a population, an underserved population, in order to provide research, these community health workers have been able to open the door and to help our participants be able to join research and be able to link them to the researchers in the community. Who do we serve? The program has no income guidelines or eligibility criteria, but in order to receive services, you just must have present a need. But the beneficiaries of the program are usually the neediest of the needy. These are residents that are below 100 to 133% of the poverty level. They may be less educated, they may only have a high school diploma or some high school, and they may not have medical coverage as other parts in the state and nation. We still have people in our Kentucky Homeplace population that do not have insurance. Some other barriers, especially for poor rural people, may include lack of knowledge about the services, inadequate information on their own conditions, social and cultural inhibitors, the lack of money, transportation, and a whole numerous other factors. Diabetes in Kentucky, as we mentioned before, we are in the stroke belt, and when you look at our counties, 68 of them are considered located in the diabetes belt. 1 in 8 adults have been diagnosed. Because of such a high rate of diabetes, Kentucky Homeplace community health workers were trained as lay leaders to deliver chronic disease self-management and also to deliver disease self-management in our population to improve our outcomes and do preventative. They can reach the people. This is one of the ways that we were able to reach many people in our communities across the state in improving diabetes outcomes, and we named this one I Do, where we do take the responsibility for our care. They were able to improve their diabetes outcomes through a nurse-led community health worker coordinated program where health outcomes did improve and our knowledge increased in self-management. Our state is also part of the stroke belt. In 2013, Kentucky had almost 24,000 non-fatal hospital visits and approximately 6,000 non-fatal emergency room department visits attributed to stroke. Overall, we were billed $950 million in 2013, and commercial payers over $225 million for stroke-related care in Kentucky. Kentucky is the center of the stroke belt. With readmissions within 12 months following discharge, patients in rehabilitation settings due to successful stroke or other complications which have been prevented. 30-day readmission rates following stroke have been shown to be anywhere between 6.4 to 12.7% and 33% at 1 year post-discharge. We discussed earlier the cost of these readmissions. According to Medicare.gov, the 30-day readmission rate for stroke nationally is 12.7, and in Kentucky that rate is between 12.4 and 15.3. Building upon the success of our Kentucky Homeplace model, we developed a program called Kentucky Care Coordination for Community Transition Program. The community health worker serves as a patient navigator and is part of the hospital team. The participants receive services from our navigator, have had no ED visits within 30 days of discharge compared to 83% of the non-participants who had at least one ED visit within 30 days of discharge. Services start upon admission, services on discharge planning team, provides home visits after the patient is discharged, provides self-management education and health coaching. This is a good example of where community health workers from the community partner with the hospital to provide services to a population to prevent hospital readmissions, but to also improve the outcomes of the patients they serve. 30 individuals, 17 females and 13 males between the age of 38 and 88 receive services in our program. 13 comorbidities plus tobacco were tracked for the participants. The highest incidence was 92% of high cholesterol, 83% of high blood pressure, 71% arthritis, 63% diabetes, and 37% depression. This demonstrates the high level of chronic disease that we have in Eastern Kentucky. 21 of these participants had more than 5 comorbidities. In comparison groups in our results, when we take a look, 92% of our participants were compliant with medication. 96% of participants attended all physician visits. 70% of our participants attended all outpatient rehabilitation visits. Without the stroke navigator, this would not have happened. Because of the work that we did with the hospital and the community with our stroke patients, a stroke support group was developed. It started in 2015. We meet monthly at the hospital. This allows the patients that have had a stroke that are admitted into the hospital to be able to attend the meetings even before they're discharged. This provides a forum for additional education to be provided. Different healthcare providers volunteer their time to provide education. The support group actually picks the topic that they want to hear about. Another study that we've completed that utilizes community health workers is called Cultural Adaptation of Collaborative Care for Depressed Appalachian Women, a community health worker model. In this program, we personalize a wellness system designed to help people self-manage their own health. We call it RAP. This helps people to decrease and prevent intrusive or troubling feelings and behaviors, increase personal empowerment, improve quality of life, and achieve their own life goals and dreams. Each person taking part of RAP creates their own wellness toolkits. Our community health workers have been trained to work with our women in Appalachia, and this is being very successful. This is one of the sessions that they're setting up for. Everything is colorful. At first, when we started the study, we thought that we would not get the number of participants needed. However, our community health workers were able to provide education to our community, and we had more people in our sessions than we ever dreamed of. When we look at prevention as part of this healthcare system, and we look at the United States, and we look at Kentucky, and then we look at our Kentucky Homeplace data, we see that our community health workers and the population they serve are able to increase screening rates when we are above the nation and the state within our screening. We are still working on our colonoscopy. However, with our FIT test, we have been able to reach many people. And I can tell you, in experience in our community, by providing a FIT test within this group, we did find some positive ones, and we're able to get them referred in for treatment, and they had positive outcomes because it was found early. When we look at colon cancer, and we look at the most recent data, we are very high in the United States with colon cancer, and we are very high in colon cancer deaths. And there are more men than women. So between the years of 2007 and 2020, the number of deaths is expected to reach up to 15.2% in men and 8.1% in women. We need to find ways that we can access preventative care and treatment for the populations that we serve. Our community health workers have been very promising skills that reach the population and help them understand the need for prevention. When we look at the screening needed, the most recent rates reported by the American Cancer Society in 2012 for adults 50 and older, 63.3% of them have been screened. That's all adults and races, not by gender. In a publication by the University of Kentucky in 2015, there was a difference in females and males as far as screening. So we do have our community health workers working with our community to provide screening and education about screening in our population. Several articles have been written about Kentucky Homeplace and the work of community health workers, and this one was titled Community Health Workers Break Barriers. This is what they do. They work with their population to bust through those barriers and of the social determinants of health to determine solutions and work with them to set goals that they can improve the health and improve their screening rates, break those barriers to transportation, to understanding the healthcare system, to navigating that healthcare system. They do provide information and health coaching to help them overcome the barriers. In another article most recently, Where You Live in Kentucky Might Cut 8 Years Off of Your Life. This is what we talked about a few minutes ago about rural areas and dying younger in the rural areas as compared to the urban areas. But one of the examples used was our Kentucky Homeplace program, where community health workers educate poor people on disease prevention and help them access medical services and other services needed. Community health workers can be part of the care team. Case management, care coordination, here are the stages. They make plans with their clients, not for their clients. They complete an initial assessment. They identify the goals of the patients. They develop team care plans. They implement the plan. They monitor outcomes. They advocate. And most importantly, they celebrate when they reach the goals and improve their outcomes. They do remove barriers. We could probably talk about barriers all day long across our nation. But one of the CDC's overarching health protection goals is healthy people in healthy places. The goal addresses the idea that the places where you live, work, learn, and play will protect and promote their health and safety, especially those people at greater risk of health disparities. One of the things that community health workers work with to remove these barriers is look at places where people can safely increase their exercise, where they can have meetings about removing these barriers, such as social economic status. Transportation is still a big one in the mountains, where we do not have taxi service, we do not have trains, we do not have buses. So that's one that they constantly work on when they're accessing services, when sometimes services are provided more than 2 hours away from home. When you look at the triple aim, which we've talked a lot about in the last few years, community health workers are very effective in improving the triple aim of healthcare. They are effective connectors. They are effective navigators. They are from a community that they are trusted by their neighbors and their friends. And because they have an unusually close understanding of their patients' lives, they are able to reach the patients that they serve. They understand their risk behaviors and how to help them improve. Their goal is to strengthen their patients' efficacy, improve medication adherence, and improve access to the quality of care. They do improve population health. They do reduce cost. We look at how community health workers educate and coach patients to be successful in preventing disease. Working with CHW teams encourages patients in self-management and care coordination. They also collect accurate patient data that allows us to look at what the goals are of the patient and to look at what the barriers are and how they improve their outcomes. They do reduce costs by coaching patients on preventative health behavior, by not visiting the ER unless absolutely necessary, finding the right care at the right place, and primary care at the right cost. They do navigate to connect their patients to community-based providers. They enhance health providers' understanding of patients' needs. So we look at when we link patients to providers, we're also linking providers to patients and having a better understanding about follow-ups and appropriate referrals. There has been a lot of national support for our community health workers over the last 10, 15 years. They've been recognized by the CDC. They've been recognized by the National Prevention Council. HHS has an action plan to reduce racial and ethnic health disparities. Many publications have come out about community health workers and how they can navigate the system and assist our patients across the country. The future of community health workers is a slate to be had. They are becoming professionals. They are being recognized. Some of our states now have a certification program, and Kentucky is one that is working on that. We're also working on reimbursement and the acceptance and the sustainability within the healthcare delivery system. In the Governing magazine this last month or so, there was an article there that says the future of healthcare is outside the doctor's office. States are increasingly investing in community health workers to improve the health of their communities. And this is a good picture here of a community health worker sitting on the front porch with a family where she is welcomed and accepted to discuss what their health care needs are and to help them to understand the preventative services and the management of self-management of their disease. In another article just lately in the Kentucky Health News, community health workers help Kentuckians deal with multiple obstacles that they have. They become a part of the healthcare system that is increasingly focused on outcomes and the social determinants of health. This is one of our community health workers featured on the right. Her name is Samantha Bowen. There's opportunities with Medicaid reimbursement for community health workers for preventative services. This is one of the rules that was handed down in January of 2014. Preventative services means services recommended by physicians or other licensed practitioner or healing arts acting within the scope of authorized practice under state law to prevent disease. This is where our community health workers can really play a role in preventing disease, disability, and other health conditions, prolong life, and promote physical and mental health within our system. Another thing that has been discussed over the last 10, 15 years is what kind of training do community health workers need in order to be successful in our communities. Within Kentucky Homeplace, we do have online pre-training that is required, such as with health insurance portability and accountability, HIPAA, research health protection, and compliance. We have trained a number of people over the past 20 years on their community health worker needs, looking at what entity they're going to be utilized in, whether it is in a hospital setting, whether it is in a health department, is it in a community setting. But the manual builds upon the 40 hours of didactic training and 80 hours of practicum time. This means that they shadow during their orientation period a seasoned community health worker that has worked in their community for some time and is able to help that community health worker see what it's like to walk in the shoes of a community health worker. And this has been very successful. The training includes 40 hours of in-class training, and they are prepared as generalists to serve in their communities. Other trainings that community health workers may receive, other than just our Kentucky Homeplace program, which really gives them a good foundation, we train all of our community health workers in basic life support. We also train them in chronic disease self-management, and they become lay leaders to work with chronic disease across the curriculum. We look at diabetes self-management, and they are trained as lay leaders. Some of our community health workers are trained in our Wellness Recovery Act plan training. Some of our community health workers are trained in mental health first aid. And then Medicaid CHIP training and Kentucky Benefit Exchange Benefine. They have been trained to be able to access insurance and access the health insurance that they need. When you look at the core competency, this is another thing that has been discussed across our nation. There are several states that have adopted their core competencies. And when you look at those, they basically include communication, the use of public health concepts and approaches as we're looking at improving public health across our country, looking at organizational and community outreach, how we can have community health days to reach the population that we're serving, to be advocates and community capacity builders, care coordination and system navigation. They are trained as health coaches as part of their competency. They need to be able to provide documentation, be able to report and manage their outcomes. They also are trained in their core competency with legal, ethics, ethical, and professional conduct. In the scope of practice for Kentucky Homeplace, they are advocates for individuals with community and community needs. They navigate the health and the human services systems. They bridge gaps through networking with communities and health social services systems to remove those barriers. They provide care coordination and work with coordination teams across the health delivery system. They provide health education, preventive health promotion, health coaching and reinforcement. They build individual and community capacity. They work building competency-based training and credentialing programs. And the big need across our country is how they develop a stable source of funding. Before we get into the discussion today, I wanted to cover a few things in the conclusion here about community health workers. They do play a significant role in reducing or managing chronic illness. They do reduce the healthcare costs, and they improve the overall health of the population. In the past few years, there are many articles that are now published about community health workers and how far they have been successful in looking at reducing the healthcare cost, improving the health of the population. And at the end of the presentation in the slides, there are many articles that have been published out of the work done within Kentucky Homeplace with our community health workers. So I hope you might be able to review some of those that might be helpful as you start a program or consider using community health workers in your system. The evidence gathered over the years makes it clear that support for and development of a community health worker workforce is a wise investment. When you look at one of the slides I had previously about return on investment, there was $5 and a few cents return on investment for every dollar spent. In the overall picture of looking at the outcomes for the people that we serve outweighs the return on investment. when you look at the readmission hospital costs, when you look at how you can improve the health of the people that you serve, that decreases the depression, that decreases the bad outcomes, such as an amputation of the foot with a diabetic who can improve their health through self-management. On the federal level, community health workers are recognized as a professional member of the healthcare workforce, and they know that they can effectively address the social determinants of health and reduce health disparities. When you're looking at working with a community health worker in the clinic, they can take care of these many issues while the providers are working at the top of their license to manage chronic disease, to make sure that the patient has what they need. The community health worker can work to remove these barriers so that at the same time they are working with their provider, the community health worker is helping them access the things that the provider has given them to do, like their medicine, their medical supplies, the things that they need. They are an important professional on the healthcare team. They are the connecting piece to the patients they serve and to the providers. Community health workers are able to share information from the patient to the providers that the patient otherwise would not be able to or not want to tell the provider, with such things like, I don't have a refrigerator, I don't have electricity. This changes the way that they can store their medication, for an example, that they can eat the correct foods that they need to do to live healthier. Not being able to have a place that is safe to exercise, to increase their physical activity when the provider is saying you need to lose weight. They are very important to the healthcare team. When you look at the success of the programs, I wanted to share just a few pictures with you. This is a team of some of our community health workers in Kentucky Homeplace and some of our Connecting Kids to Coverage workers that we have across our region. And also in the past year, they have been very diligent in developing the Kentucky Association of Community Health Workers, where they have a voice to talk about what community health workers do. They are helping us determine additions to their scope of work or changes that might be there. They are at the table as we are looking at providing certification for our community health workers. They have a voice in the state of Kentucky, and they have a voice across the nation about what future community health workers can do, who they are, who they serve, and where they work. So we're very proud of the group that they are able to come together as a state and look at the needs of our state as far as the patients and clients that we serve, and also look at the needs of our community health workers, such as education that they need, such as tools that they need in order to be successful while they're working with the many different entities across the country and in their communities to improve the health of their populations. We did get through our slides a little bit early today, so I am open to questions about our community health workers here in Kentucky or anything else that I can help you with today.
Thank you,
Kim,
Fran.
I'll turn it over to you.
Yeah, that was a great presentation. Everyone, if you want to type a question for Fran into the chat box, you may do that now, or you can press *2 to unmute your phone line and ask Fran a question. Fran, we do have a question here. If a hospital or other organization wanted to include a community health worker on staff, what would you recommend they do? Where do they start? What department does the community health worker usually report to?
Those are really good questions, and I'll take the first one. the starting place would be to look at what the need is, what you want the community health worker to do. And in that, you would want to build upon a job description for your community health worker that fits that need. You would also want to include your community members. You might have an advisory board for that hospital. You might have a community organization. You want to develop and there's many job descriptions out there across the nation about community health workers, and I'd be happy to share our description that we use in Kentucky Homeplace with anyone. But first determine what it is that you want them to do. Do you want them to work in the emergency room to identify people that need to be screened, have preventative screening for cancer that normally do not seek out primary care? Do you want them to work with the patients that are hospital readmissions that are coming in before that 30-day period to reduce hospital admissions and to help the patients improve their care? So you need to know, first of all, what it is that that you want that community health worker to do. The other thing